So good afternoon, colleagues. So we are in day 4 of our free CPD presentations, and we have to start. We still have Dr. Esther Okai continuing with her presentation. And Dr. Okai, are you with us?
Yes, Dr. Kwashi.
Kindly take over the floor.
Good evening, everyone. Is my screen visible? Hello, Dr. Kwashi. Can you see my screen, please? Okay. Hello, Dr. Kwashi. Anyone, can I be heard or seen?
Yeah, please, you can be heard loud and clear. The screen is visible.
Thank you very much so far. Today, we continue with our training day 4. But before we start, I want to say a big thank you once again to the leadership of Gamls for such a speech. I believe that we will both learn as we go through this session. Today, we are looking at culture of body fluids 2. And today,
Dr. Okai, I think you have to reposition yourself today. We've started having the
we are
breakages.
treating blood and cerebrospinal. Aim is that by the end of this session, we should see a step. Dr. Kwashi.
Yeah, so I was saying that we are having a break in your feed. If you can position yourself very well so that today will be a best presentation as it comes to this.
Okay. All right. Kindly let me know if it is better as I speak.
I think it's better now.
All right. So we'll also learn how to properly collect blood culture samples and then how to process it. Today we are doing manual blood culture processing. And so what is CSF? It is a clear, watery liquid that flows around the brain and the spinal cord. And it provides several functions, including giving buoyancy. Just looking at the size of the brain, being supported by a few nerve endings, nerve cells. The net weight of the brain is about 1,400 grams. So the buoyancy provided by the fluid around it gives it a weight of 50 grams. So it supports the brain. It prevents it from injury, or it absorbs shock anytime the brain hits the cranium. It also clears waste from the CSF into the brain. Now, in an adult, the total volume of CSF produced is between 90 to 150 ml. And in newborns, it is 10 to 60 ml. And this CSF is produced, circulates, and then reabsorbed into the blood. And 500 ml of CSF is produced every day, which means that CSF around the brain and the spinal cord is replaced every few hours. In normal CSF, we may have a few white cells and then some small amount of protein and glucose. So why will a physician ask for a CSF culture? When the physician suspects any disease affecting the central nervous system, such as meningitis, of bacterial or fungal or parasitic etiology, they will go in and ask for a CSF culture. CSF by itself can be processed in many different ways, but when it comes to culture, these are some of the reasons why it is requested. Now, how is the sample collected? This is collected by a trained health professional under aseptic conditions to avoid contamination. Now, the lumbar puncture is the name of the process, or spinal tap, where a needle, sterile needle, is inserted between the third and fourth lumbar to collect this CSF sample. Now, usually, at a point of collection, about 3 tubes, in some cases 4 tubes, are collected. 1 tube is for cell counts, so usually in EDTA tube. Another tube is for chemical tests, including glucose, and so it is advisable to use the oxalate tube. And then the other tube is for cultures, where we use a sterling tube, which should be sterile. This is how it looks. Usually, not much volume is picked, and so these are the ideal specified tubes for CSF, small and sterile. All right, so what tests can be done when a physician wants a CSF culture? We can look for the color and the appearance. We can look for protein, glucose, the cell count, cell differential, microbial stain, routine culture, A and B culture, and then some molecular tests for some genetic material in some of the pathogens. But CSF protein and glucose and the cell differential count is usually reserved for the chemical pathology and hematology laboratories. So if you are supposed to do a CSF culture, you need a few equipment and materials. You need your microscope, incubator for incubation. You need a hot air oven, a source of heat for flaming your loops, that's the Bunsen burner or bastinerator. The media you use, you need the blood agar, chocolate agar, McConkey agar, and subbrodextrose agar, sensitivity test agar, peptone water, and some identification media are required. We also need antibiotic discs to help in finding drugs for the possible pathogen. Then plasma and saline. We need our stains, Gram stain, Zil-Nielsen stain, this time around Indian ink. And we need 3% glacial acetic acid. We need pasta pipettes. This time around, it should be sterile pasta pipettes or sterile capillary tube. We need a counting chamber, a tally counter, some slides, cover slips, forceps, a straight edge, or a measuring device to help you measure your zone of inhibition. So when your sample reaches you, first you have to sort out the sample, make sure that the request, the name on the request or information on the request matches with what is on the sample. And then you log into your laboratory book and give an accession number. When we look at the process in which the sample was collected, it is an invasive, painful process. And so CSF is one of the special samples. All samples are special. However, CSF needs extra attention, extra care. And so even from point of collection, as soon as the sample is collected, it should be transported straight to the laboratory for analysis. And this information should go to the various points of collections in the hospital. The physicians, the nurses, they should know. I'm sure they know, but we should reiterate the importance of them bringing the sample to the lab immediately after collection. And then once it gets to the lab, we do not have to refrigerate the sample. Like we said yesterday, some of the samples, some of the body fluids, they contain some pathogens that are sensitive to cold temperature. And so you do not need to refrigerate them before culture. You can culture them and then later refrigerate as a way of preserving the sample for future use. So ideally, you culture them before refrigerating. Now, after sorting out the sample, giving it a number, we have to describe how it looks. That's the macroscopic examination of the sample. So we look out for the appearance. So we report the color, the turbidity, the viscosity. As you can see here, these are 3 different cerebrospinal fluids. Of course, when you are describing, this will have a different color. The name of this color will be different. This color will also be different. And we'll talk about it when we get to the interpretation of reports. All right. After you have described it macroscopically, you go ahead and do your cell count. And this is an alternate test for what is done as hematology departments. So in the hematology department, the sample is run through the hematology analyzer to give you the cell count and give the differential. It goes ahead and give you the types of cells. But for the new bar, we are just counting the white cells present. For the cell counting culture, we are counting the white cells present. So you clean your counting chamber, you charge it, you cover it with a cover slip, and usually it comes with its cover slip, and it is thick, designed to be thick, so that when we put fluid under it, the fluid doesn't cause the cover slip to float. So usually when we break it, we put on our own cover slip, which is a bit light, it's thin. So sometimes when you charge the counting chamber, you can get it lifting a bit, affecting the volume under the chamber. And so it's ideal to use the cover slip that came with the counting chamber. It's a bit thick. So you charge it, you put on the cover slip, and you look out for Newton's rings around the edges, this place, and that tells you that it is securely attached. And then with a sterile pasta pipette, a sterile small tip pasta pipette, or a sterile capillary tube, we pick a few volume of the CSF and charge the counting chamber. All right. So this is the sterile. You see some of the pasta pipettes, some come all in one big Ziploc bag, and some come individually in a sachet. Those ones are sterile, and those ones can be used for the CSF cell count loading. If you realize that your sample is turbid, it is cloudy, you need to go ahead and do a dilution. You do 1 in 10 dilution, or 1 in 5 dilution, or 1 in 20 dilution based on the turbidity of the specimen. Okay, if the specimen is blood stained, you can dilute the specimen with glacial acetic acid, 3%. This will help break the red cells in there and allow you to see your white cells, to count them. All right. Now, if the specimen is bloody, I was looking for a bloody specimen to show, but I just couldn't find one. So the bloody is just like blood. It's so thick. And the blood stain, you can see changes of blood. It's like hemolyzed blood in there. So for the blood stain, you can lyse with glacial acetic acid. But for the bloody samples, you report as unsuitable for cell counts. All right. So after charging, you allow some few minutes for it to set in a petri dish with a wet tissue so that it will not dry. Allow the cells to set, and then you count. You start with the times 10 and then zoom into the times 40, looking for your white cells. And please take note that you see white cells and not red cells. You count white cells and not red cells. And you count with a phosphorescent, you count 4 edges and any of the middle squares, all together making 5 squares. And as you're counting, you bear in mind the L rule, the left bottom line. You count cells on the left bottom line or you count cells on the up right line. So it's either you choose to count the cells on the left and the bottom and leave every cell here, or vice versa. But thankfully, the cell count in hematology has come to take away some of these lapses and some of these, let me say, obsolete methods. So this is showing a red cell. You can see the biconcave in here, and then the white cell with the nuclear material in here. So this should help us identify a red cell from a white cell. All right. So after you have described the microscopy of the sample and you have gone ahead to count your white cells in your counting chamber, you aspirate the CSF into a cryotube, a sterile cryotube or Falcon tube. And then you cap it and centrifuge at 3,000 revolutions per minute for 5 to 10 minutes. Centrifuge at 3,000 revolutions per minute for 5 to 10 minutes. And the idea of this is to concentrate the CSF. We are now looking for bacteria or any microbe in there. So for the cell count, we want to see how many white cells are in the undisturbed CSF. But for the culture or the gram stain, we want to concentrate and catch any possible pathogen in there. And so we spin it, and then after the time, we separate the top into a tube and label supernatant. It can be used for other tests. And then we label the deposits as deposits or sediments. You label it so that I won't confuse you. Then with the sediments, you come ahead and do a wet preparation. So you take a drop of the sediments, put on it and a slide, apply a cover slip, and then you are looking for amoebic forms or trypanosomes. So there's this parasite called Naegleria fowleri. I don't know if we have recorded it in Ghana, but I know it's in most of the Western world, and it's a very pathogenic parasite. Usually before you are able to identify it, the patient is dead. And so you can see some of these forms in the motile form, in the wet preparation, and the trypanosomes can also be seen in there. So when your specimen is old, you know that you won't see the motile forms. That is why testing CSF is paramount. When it comes to transport, it should be sent immediately to the laboratory. Now, when it comes to staining, we have to do gram stain. It is mandatory. We are doing gram stain to look for cells, bacteria, whatever it is we can get from our gram stain. Then if tuberculosis is suspected or is requested by the physician, we go ahead and do a ZM stain. And then if cryptococcus infection is suspected by the physician, we go ahead and stain with Indian ink. Okay, so even if the doctor did not request for crypto, and let's say that the patient is coming from the previous units or the HIV ward, that is if your hospital has something and you see the diagnosis, you can go ahead and look for crypto because it is usually found in immunosuppressed people. All right. So after the staining, we go ahead and still pick the deposits and culture onto BA, CA, and McConkey. And then you incubate the BA McConkey in ambient air, and you put the CA you put the CA into the candle jar like we discussed yesterday so that we can create some microaerophilic condition for bacteria that requires that to grow. And also here, several streak techniques can be used. Several streak techniques like we discussed can be used. We can use the quadrants, or we can use the Christmas tree streak that we spoke about, the continuous streak we spoke about, I think, yesterday. All right. So on the second day, so all that was done on the first day: macroscopic identification, cell counts, staining, and then culture plate inoculation. They were all done on the first day. Then on the second day, you come and look out for any plates, any growth on your plates. So whatever you have grown on your plates, like we discussed, you have to do a gram stain to tell you whether it is gram positive or gram negative. Even if it's gram negative, whether it's cocci or rods, all these things will inform how you do your further analysis, will direct your next step. So even a gram can show you the type of identification test to do. From here, you can decide to do these normal TSIs, indocitrates. You can decide to do coagulase. You can decide to do your Pasteur's test. So you can know which lane to toe from what your gram reaction and your colonial morphology is giving you. And then you go ahead and you do your sensitivity appropriately using the right drugs. Then on day 3, we come and read our identification test outcome. We will read our AST outcome, and then we validate the reports and then send the reports out to the physician. Now, like we discussed yesterday, all samples taken across the skin barrier are likely to be contaminated by normal skin flora. And so anytime you place such samples, you have to always rule out normal skin flora. Okay, so you follow all isolates because the CSF is sterile, it's from a sterile site. You follow all isolates with exception of probable skin flora or obvious plate contaminants. You perform your AST and your ID according to CLS guidelines, and then you document your results and dispatch. Now we have to be, all right. Now for CSF, the report should go to the physician as soon as possible. For CSF, we have a preliminary report and then the final report. Likewise, for blood culture, we have a preliminary report and then a final report. For the preliminary reports, you have to let the appearance, the gram, and then the wet preparation and the cell count results go out whilst we await the other tests. So when we come to report interpretation, for color, in normal CSF, it should be colorless. But sometimes there can be xanthochromic, which is yellowish in color, yellow coloration. And this may be due to increase in protein or red cell breakdown. Okay, we can have pink or orange CSF also due to breakdown of RBC or presence of bilirubin in the CSF. We can have green color CSF, which is indicative of infection or bilirubin. Then there can be hemorrhagic CSF. That's why we have the bloody or the blood-stained CSF. And usually this is as a result of traumatic sampling. Okay, but there's also a condition where there can be hemorrhagic conditions in the CSF itself. So how do we differentiate traumatic procedure from when the patient really has a bleeding in the CSF? So usually what is done is that the physician is supposed to aspirate 3 tubes. So the first tube comes, is bloody. The second tube comes, is bloody. The third tube comes, is bloody or bloodstained. Then we know that truly there's something going on in the patient. There's a bleed in there. But when the first tube comes, it's bloody. The second tube comes, it's clear. The third tube comes, it is clear. Then you can tell that the blood is as a result of the traumatic procedure. We can also have the turbidity being abnormal, showing cloudy or turbid. So you can't read through. In these cases is when we have some white cells or RBCs or even microbes and even protein increase in the CSF. Aside that, a normal CSF should be clear and colorless. That means the color should be colorless, the turbidity should be clear, the viscosity should be like that of water. So sometimes when you have a thick CSF, it could be indication of meningitis or even in some cancer cases. When you have a fibrin clot in CSF, it should be reported. It could be an indication of tuberculosis in there. All right. So when we come to the cell counts, a normal CSF that is clear and colorless should have less than or up to 5 cells in there. But for neonates, of course, even when it comes to blood itself, they always have a variation in their cell counts compared to us. So for neonates, up to 30 is okay. So if you have, and you count yourself, and you have 30 cells times 10 to the power 6 per liter. So are you going to treat it as an adult or as a unit? My internet is unstable. Is it better? Can I be heard?
Yes, please. You are okay.
Thank you. So if there is no age on the treat it as a unit, you treat it as an adult. This is why our request forms should be properly filled. All right. So when it comes to the wet prep, for a normal scene, I remember once, I've seen it only once, a CSF cell count, and there were lots of trypanosomes in there. So many trypanosomes in there. All right. Then for the Z, normal CSF should have no ABs of different forms. Normal CSF will have bacteria, or you can see some fungal forms or even parasitic forms staying in there. And then you may see moderate to high WBCs in the grams stain. The Indian ink, a normal one should have no crypto cells seen, but abnormal, you see your crypto cells. And I brought this picture here because it is something that a lot of us miss. I think some of us may even wrongly say it is yeast-like cells, even though it will be difficult to see in just normal microscopy. But here, Indian ink stain is a negative stain, so it will stain the background, and then the capsule around the crypto will not take up the stain. So you see this refractile crypto cells in the dark background. So you can use Indian stain or neurostin to achieve that. And then for culture, a normal CSF should have no bacterial growth. But for an abnormal CSF, you can have bacterial growth or fungal growth. And like we said, anytime you grow something from a sterile site, you should be alarmed because a sterile site should have no bacteria. However, once it is taken across the skin barrier, you should always want to rule out skin contaminants. And so if you grow Staph epidermidis from a CSF, you should not be in a hurry to perform sensitivity and send to the physician. All right. Then for the chemical test aspects, where we take to chemical pathology. So like we said, in normal CSF, there's a small amount of glucose. So usually it is to test the concentration of what is in the blood. But when bacteria or white cells or even some tumor cells are present, they use up the glucose and decrease the levels. So for a normal range, you should get between 2.2 to 3.9 millimole per liter of glucose. So when it is below this, you know that there has been some use up. Proteins are normal there, a small amount there, 0.15 to 0.45. When you have increased protein, it tells you that there's been a breach in the blood-brain barrier. I have to be careful with that. In the blood-brain barrier, allowing proteins that are macromolecules to seep through in there. And so this can happen when you have, there are so many conditions that can cause this to happen, high protein. But with the considering microbial etiology, meningitis, or even syphilis can cause that. So like I said, preliminary reports should be taken to the physician on the same day the sample was received. This tells us that we have a lot to do in all of our labs. On the same day the sample is received, the preliminary report should be taken out. The appearance, the cell count, the gram stain, or any other stain that was requested, and the wet preparation should be taken out, whilst the final report will contain the preliminary or changes in the preliminary, plus the culture, either no bacterial growth or bacterial growth with the appropriate sensitivity pattern. And even when the final report is ready, it should be immediately communicated to the physician. And so this brings us to the end of our discussion for the cerebrospinal fluid processing. So we'll move on to blood culture. So blood culture is a test done to find out the presence of any microbe or pathogen in the blood, bacteria or fungi. Blood culture cannot recover viruses. It can recover bacteria. It can recover fungi. Blood culture you cannot culture parasites, but you may see the parasites during your staining processes. And it is done for three main reasons: to confirm the presence of a pathogen that is causing an infection, to identify that pathogen, and then to give antimicrobial guidance in therapy. So when will a physician ask for blood culture? Usually when they have undetermined cause of fever, that is more than 38 degrees Celsius, or hypothermia. And when there are signs of sepsis, like chills, rigor, high heart rate, low BP, they can request for a culture of the blood. When sometimes there are severe local infections, they may request for a blood culture. Or when the person is done with treatment, they can request for it as a form of checking if everything is okay. So today, we will talk about the manual blood culture. We'll talk about the automated version tomorrow. So the manual blood culture is what we were all using until automated started coming in. And it came in trying to help. But along the way, we got stuck, because I'm saying this because in my lab, for instance, a whole year, we cannot be there without running blood culture, all because of procurement, this, that. And I think as a lab, we shouldn't put aside our old methods of running tests. We should do it alongside. If we are having blood culture manual and we have issues with the automated, we can quickly go back and fall on the manual and still help our clients. So to work on blood culture, we need the usual microscope. You need your incubator, hot LV, Benson, Bena. You need your blood culture medium. So we can either use BHI broth or thioglycolate broth. You also need your BAC, McConkey. You need your identification media. You need your antibiotics. You need your stains, and you need your miscellaneous items to help you in your work. All right. So very important is the sample collection, because so many times we get contaminated blood cultures because of poor sample collection. And a blood culture should be collected appropriately before antibiotics are given. They should be collected before antimicrobial therapy is given. And it should be collected as soon as the person sees the symptoms or the signs. And then it should be collected when there is in between spikes of the patient. So when a patient has taken antibiotics, that is when some of these are modern blood culture systems come in, because they have incorporated some components that is able to absorb or mop up the traces of the antibiotics in the blood, allowing the test to go on unaffected. So here is where we will have an advantage of the automated blood culture system over the manual blood culture system. So how is the blood collected? In the usual phlebotomy process with your syringe and needle. So very important. I was once, one of my researches, we're having so many contaminants in the blood cultures. You bring it to the lab, you put it in the backtech machine. In about 30 to 1 hour time, it is beeping positive. You go, you do everything, pass loss. So I went back to the sites and I inspected how they collected the blood sample. I didn't tell them that I have gotten contamination so many times. That's why I'm there. So I just went and I was inspecting, because I don't want to tell them so that they will start doing it by the books. So I realized that after the person has decontaminated or cleaned, disinfected the site from an impingement, then he goes ahead with a dry cotton and cleans it before he goes in. And I was like, aha, this is where we are getting our contaminants from. So I had to educate him. So when you disinfect the place, allow it to air dry. Don't be in a hurry to go in and apply your dry cotton. Allow it to air dry. If it is available, you apply 2% tincture iodine and then allow it to air dry. And please, I believe you all know the concentric way of disinfecting from the center outward. Okay, we don't go and come inside, from the center outward. And then this is the broth, the blood culture broth in a universal bottle. Could be BHI broth or thioglycolate broth. So this is prepared manually in the lab. And usually, I couldn't get a good example on the internet. On the cover, there's a small hole in the cup, but the hole doesn't enter the seal in the cup. You know, when you open the cup, there's this plastic seal. The hole made does not perforate the plastic seal. So the seal gives it some protection, and the hole allows you to empty your blood in there. So after you go in, so this is prepared. Usually it is 18 mils of broth in the bottle. In the olden days, we had a larger size bottle where we had 45 mils that we used for adults. But usually now I see just the small bottle. So for the 18 mils, you take about 1 to 2 mils of blood. I'm saying 1 to 2 because you can have children with difficulty in bleeding. So you take the 1 to 2 mils of blood and then you add to your thioglycolate broth. Now, very important, the needle that you inserted in the patient, when you come out, change the needle, use a new needle, attach it to your syringe, and then dispense it into your culture broth. Let me say again, once you come out, change the needle and attach it to the syringe, and then dispense into the broth. This is to prevent contamination of the tests. But before then, you also wipe the top of the bottle with alcohol swab, allowed to air dry before you use it. Once you put it in, you swell it quickly, label it properly, and then you quickly send it to the lab for analysis. So with this said, I'll move to this flow chart. I believe you can see the flow chart well. I hope it's not too small. Okay. Is it okay?
Oh yeah, don't be afraid. It is okay.
Okay, thank you. So this is the flow chart, or this is the protocol for manual blood culture. So once the sample gets to the lab, you sort it out, and then you give it a lab accession number, and then you start the process. But before you do that, you also want to check whether the sample is acceptable. Maybe the sample was not taken in your presence. You check whether there's no leakage of the sample all over the bottle. There are no cracks. There's no visible foreign objects in the bottle. So if all these are okay, then you go ahead and accept your sample. Once the sample comes, there's a special tray, a wooden box made for this bottle. So you put your sample in your bottle, your box, and then you incubate overnight. That is day 1. So day 2, you come out, and then you bring out the bottle. You are performing your first subculture. So you bring out the broth, and then you subculture it onto blood agar, chocolate agar, and McConkey agar. And then you put the broth back into the incubator, and then you incubate the plates alongside, bearing in mind that your TA always goes in your candle jar for the CO2 incubation. Then you incubate overnight. On the 3rd day, you come out, you pick out your plates, evidence of growth. Okay, so you pick up your plates. If there is growth, no, there is no growth. Then if there is no growth of the plates, you continue incubation of the bottle. So if there is growth, you come and perform your gram test. Let me just take the growth aspect. So on the 3rd day, you come, you pick your plates. If there's growth, yes. So if there's growth, you come. The first thing we do, as we all know now, we do your gram to know which lane to tow. Then you do your further identification based on your gram reaction, whether you do coagulase, whether you do indo, whether you do you rule out dominance with oxidase. You do all these tests for your identification, and then you perform your AST if needed. So if you do your coagulase and it is negative, you don't need to do AST. But if you do your coagulase and it is positive, you go ahead and you do your AST. And then you report your final to the physician. Okay. However, if there is no growth, you re-incubate the broth. And as you are re-incubating, from day 4, from day 3, day 4, and day 5, every morning you come, you gently bring out your broth, and you look out for evidence of growth. So the evidence of growth, this is a liquid medium. So the first thing I believe we are all thinking about is what? Stability of the medium. There could be white specks in the medium. When you bring out the bottle gently, sometimes the evidence of growth will be bubbles on top of the medium. It's showing you this gas exchange. So you see bubbles on top of the medium. But if you are bringing it out and it falls down, the bottle falls down and stands up, you will see bubbles. That doesn't mean it is evidence of growth. That is why you have to bring it out gently so that if there's bubbles, you know it is truly from your test, not from you mishandling the bottle. Another evidence of growth is hemolysis of the medium, or sometimes coagulation of the blood inside the medium. So for day 3, you come out, you pick out, you check. Evidence of growth, yes or no? No evidence of growth, you put it back. Day 4, you come, you bring it out. Is there evidence of growth? No, you put it back. Day 5, you bring it out. Is there evidence of growth? No, you put it back. So bear in mind, you are always documenting this because in the laboratory, we don't work alone. So day 1, when there's no, day 3, no evidence of growth, you write D3, MBJ. D4, you write dash, no evidence of growth. D5, you document behind the patient's card so that tomorrow when your husband takes you to US, the person who comes to work can continue the work. So you don't keep the reports in your head. So every day you document whatever you are seeing. Then on day 5, if there's still no evidence of growth, you re-incubate, you re-incubate till the 6th day, and then you do your subculture. On the last day, the 6th day, you do your subculture, your last subculture, and then you wait out for the result on the 7th day. If there is evidence of growth, you go ahead and subculture onto BACA McConkey, like you did at the top here. So for this process, it is a long 7 days. So on day 6, you bring it out and perform your last subculture on BACA McConkey, and then you incubate. If there is no growth, you say no bacterial growth as your final report. If there is growth, you go back and perform identification and sensitivity if appropriate. But usually in people who are very sick, if there is really an infection between day 1, day 2, day 3, day 4, something should have grown. So usually after day 3, day 4, you are sure that maybe whatever will grow could be a contaminant. So this is the simple workflow for manual blood culture. So you receive your sample. Is it acceptable? No. Then you go through your sample rejection protocol. Is it acceptable? Yes. You incubate on day 1, day 2, you come out, you bring it out for your subculture. Day 3, you read. If there is growth, you do your AST and you report the isolate and drugs to the physician. If there is no growth, you continue incubation. You continue incubation till the 6th day. And during the 3, 4, 5 days, you are bringing it out, looking for evidence of growth that I spoke about. Teresa, I think it's too early to raise your hand, maybe when I'm done. So the 3, 4, 5, you be looking for evidence of growth. And then if there is none, on day 6, you bring it out and you do your last subculture onto BACA McConkey. And then you come out and look for growth. If there's growth, you do the necessary identification and sensitivity if applicable. If there's no growth, you come out 7 days saying no bacterial growth after 7 days. So bear in mind that the 48 hours growth, the 48 hours incubation has to go to the physician. So you give the physician the gram reaction, no bacterial growth, no organism seen, that's gram. And then the culture, no bacterial growth after 48 hours of incubation. Then on the 7th day, you let it go out as no bacterial growth after 7 days of incubation. Now, in some conditions, endocarditis, we have to incubate the blood for a longer time, 21 days. So for that, you'll be doing the manual inspection, or like the visual inspection every day till you do the visual inspection. I think on the 10th day, you subculture. On the other 20th day, you subculture to have the last report on the 21st day. But you have to incubate it for that long. Now, like I said, you report your 48 hours to the physician. And then if there's a bacillus species, you report it as contaminant. Or staph epidermidis, you could report as a probable contaminant. A probable contaminant because in so many cases, staph epidermidis we thought was a contaminant, but was able to cause infection in a patient. Usually you get to know this when you are sure of the sample collection that it was aseptic or it was under good laboratory process. And then you have recovered the staph epidermidis 2 or 3 times from the same patient who is not recovering, who is not like doing well with the medication. Then you know that the staph epidermidis is truly causing an infection in there. Candida species is also reported. In fact, when you do your gram stain and you see your Candida species after 48 hours, on the 48 hours, the gram stain showing Candida, immediately go and look for the patient and send the report out. Okay. And then your final report will be no bacterial growth after 7 days. And then for those that have pathogenic isolates in there, you take the bacterial growth and the appropriate drugs required for treatment. So like we said yesterday, every stage of a lab test, all the tests in the protocol, wherever applicable, we should set controls and document these controls as a lab doing quality work. And then you keep the specimen all the way till the report is ready and the report is given out before you can duly dispatch your reports. You can stock your isolates for further, like yesterday we were talking about, was it 2 days ago, biobanking and how Gamls is looking forward to have its own biobank. Stocking isolates to feed this process will be ideal. And then safety is paramount. Safety is very important. We don't have to come to the lab and get infections from the lab. So we have to wear our gloves, segregate our waste well, know that the microbes or the samples we are dealing with contains hazardous microbes. We use hot surfaces in the lab. Our incinerator can be hot, or the gas, the flame can be hot. You can get burns there. In the lab, you will see bacteriology lab. Anytime I see my ladies, interns especially, with their long hair or big hair, I'm like, fire will catch your hair. So you put into consideration all those hazards. There could be spores, inhalation, splashes into the eye, and the lab is not a place for unauthorized people. All right. So today's class is very short, and I believe we were able to grasp something. Thank you very much. Over to you, Dr. Edujesi and Dr. Fashi.
Dr. Edujesi, please, over to you.
Yeah, thank you very much, GS, and thank you very much, Dr. Esther Okine. I think it's been great time having your experience shared with the entire medical laboratory fraternity. Almost all the time, the link is filled to capacity 500, and we have a lot of people also joining always on YouTube, and many others go back to watch. So I think a lot is happening around. Those that even get back to me asking for your name and how they can contact you. So I won't be surprised a lot are getting to reach up to you. So we appreciate what you are doing for us. And as we always do, I think we want to read through some of the comments and see how we get responses. But before that, we have Michael Bafo Asari. That's the only hand raised. So I want to take his comment, his contribution, his suggestion, and before I get to read some of the questions in the chat. So Michael. Yes, kindly check the settings if you may have to unlock people to unmute.
Michael, try and unmute.
Hello? Hello?
Please go ahead.
Yes, please. Thank you, boss. Thank you, Dr. Exter. I think your presentation, as always, is on point. And I'm so glad. I also pride myself to be your friend, your boyfriend, and everything. I mean, you have to keep it up. And I hope our senior people are looking at you. And very soon, we are going to make the place a better one for all of us. But there were some few suggestions that I wanted to bring across, and then a few questions I wanted to ask you from today's presentation. And most of them actually come with the CSF presentation. So as one of your old professors with important specimen, and that one we cannot argue much. We actually even look at how the sampling is done. I would be glad if one day maybe we all find the opportunity to actually go to the ward where the samples are being taken. And then we see how important it is when it comes to CSF and its processing. So for that matter, somebody was actually asking of rejection criteria. And in one of our current presentations, it actually came up. So they were looking at traces that may actually lead us to suspect that there's contamination or whatsoever. But as it came out in our discussion, for CSF, because of the nature of the sampling and the dangers associated, even a repeat is not an option on the part of the doctor. Because I tell people that if I am sane and I'm in the ward looking at the danger, it will be very hard for me to even allow you to take my sample, because you can even paralyze a patient in the process. So what I say is that when a CSF sample gets to us in the laboratory, first of all, let us take our time, assess the sample, find out the state in which we received it, and document everything before we decide what to do next in terms of processing. So
Okay. It looks like Michael's line. That's fine. So I think he's added on, he's cautioned.
that if anything comes out and we are suspecting that probably it's a contamination or whatsoever,
Yeah,
we still
Michael.
should not be hasty in us. Yes, sir. Please, can you hear me?
Yeah, in fact, you were dragging, and so now you are clear.
Okay.
You can go on.
I can go on. Yes. So what I was saying is that for CSF sample, when it gets to us, we shouldn't be hasty in concluding as to whether it's a bad sample, and for that matter, we want to reject it outright. No, let us document every detail about it, whether even the sample even came to us on time, because actually the doctor or whoever takes the sample should even put the time on it, because for fastidious organisms, even during transportation, some of them may perish before they get to you. And then that brings me to my next point, whereby we have to actually pay attention to the primary identifications that we have to do. Because for these fastidious organisms, some of us will reach us already dead. But that doesn't end there, because if we do our gram staining very, very well, and then we are able to actually see the cell types that are present over there, even if they are dead, they will still be intact for the purposes of gram staining. And gram staining as one technique can actually help the clinician in managing the patient. Because I remember one particular case like that, where the sample got to us. I think it was late in the evening, so our shift was almost over. And then we had to quickly do the gram staining. But lo and behold, it wasn't even a pathogen that we would suspect on a normal day in a CSF specimen. It was Salmonella for under 5-year-old baby. And then quickly we had to go to the ward, give the results to the doctor. The doctor was so happy because apparently the medication that he had actually started the child on wasn't appropriate. So he switched. And within a matter of days, when the final result came out, it turned out to be Salmonella. But obviously, the child's life was saved. So these are some of the things that we have to really look at when it comes to the primary aspect. And then for serology too, we have to still do serology because for organisms like strep pneumo, if it is there and it dies, serology can still pick it up. And we can still go ahead and give the results to the doctor for him to initiate some treatment. And then last but not the least, I think, Esther, in our past, you remember that whenever we do a cell count, and then the cell count is above the range, irrespective of whether the doctor actually even requested for a culture or not, we would go ahead and actually put an aliquot of the specimen into an enrichment medium, just to make sure that, just as yesterday you said, we'll pamper them if there are any fastidious organism. So within a matter of 48 hours, there's a likelihood that they may grow, because it's not all the case that you can pick it up the first day. And with this, if the doctor is just dealing with the gram, just the cell count results, that will not be enough. But at least you have given an extra information to the doctor, which will also be very helpful in managing the patient. Thank you very much. Thank you, Esther. God bless you for blessing our profession.
Thank
All right.
you
Thank you very much, Michael, for adding on. So, Seidu Ajewa Teresa, can you unmute and ask your question or suggestion?
All right. Good evening to everyone on this page. Hello.
Yeah, please, good evening. Go ahead.
Thank you so much for the wonderful lectures. This was my question. It was like I was not very clear on that, and I wanted to clarify myself. Like, I wanted to know whether you report when you see any growth before the 7th day, or you still have to wait for the 7th day before you send your results out. Please, this is my question. Thank you.
All right. Dr. Okai,
Yes.
when do you report?
So, Teresa, you can report at any point you isolate something. You don't have to wait for the 7th day. And I think I was very clear and emphatic about that. So you report 48 hours, and then after the 48 hours, anytime you recover anything from your test, you should quickly report to the physician. Thank you.
Okay. Thank you, Mama Esther. Thanks so much.
All right. Thank you. Maybe if I could just add, I have worked with protocols that will tell you after a certain number of days, if you are picking up an isolate that they show up in the first 2, 3, 4 days, then you may be dealing with a contaminant. So you want to investigate before you go ahead to report. So it depends on maybe some of the protocols and what really you are expecting. But as she said, it's important you take note of everything you grow. But some may raise questions of whether you need to investigate if you are not dealing with a contaminant. Okay.
Thanks.
So Ruth, that's all the name. Ruth, if you can also unmute and. Ruth, can you unmute? Whilst Obed Odoi Asedu also prepares. Okay, I think Obed can take up. I'm not getting Ruth to unmute. So Obed Odoi, kindly unmute and ask your question. Okay, it looks like the hands that were raised are not able to unmute or pay attention. So please, I can go through some of the questions that we have here. From Isaiah Eche Amuyao. Yeah. Please, do we have a special metric automated machine for WBC count in CSF? Dr. Okai.
Thank you. So, like I said, hematology analyzer, and then just that the reference ranges have to be set for that. The ranges are not the same as for blood. Hematology analyzer can be used to run CSF cell counts. That is why we advocate
Doc, I don't know if it's my end, but you are breaking. Once you started and you said hematology analyzer, I can't hear you again.
that 3 samples are taken. Hello, Dr. BJC.
Yeah, so I only heard up to hematology analyzer and you were off.
Wow. Okay, so I was saying our analysis for hematology counts can be used for CSF cell counts. That is why we recommend samples collected for that in EDTA. So 1 sample for hematology, 1 for chemical analysis, and then 1 for culture. So you can use your Sysmex or whichever analyzer you have for hematology to count your cells. It is the reference ranges that have to be looked at because they are a bit lower than for the routine blood. Thank you.
Thank you very much. All right. So I think others are very happy and asking for the slides. So one bright Atamensa is asking, please, can't you use a gram stain and wet prep of the deposit to screen for Cryptococcus instead of going ahead to stain with Indian ink?
Okay. Right, Tata. Like I said, crypto has a capsule, and those are demonstrated via negative staining. And so you may miss them in your gram. Even if it takes, you may misidentify them as candida. So the best is to use your Indian ink or Negro stain, where you see the refractile, let me be careful, refractile crypto cells in the dark background. So it is always ideal to do your negative staining for the crypto than gram. Thank you.
All right. So Richard Nyami, your previous question was answered using the hematology analyzer on the CSF for cell count. But you have one other question. Please, with laboratories that no longer perform ZN but use Oramin for fluorescent microscopy, can the Oramin stain be used on CSF for suspected TB infections?
From the specimen, yes, it can be used. Once the Oramin is able to identify your microbacterium, you can use it for your CSF. In fact, CSF samples can be taken for gene expert analysis, for AFB cultures as well. So if you have any other protocol that can recover AFBs or identify microbacterium, you can use it for CSF. But it will be prudent to spin it down, concentrate it. Thank you.
All right, thank you. So it looks like this sample rejection is coming up. So I would wish you may reiterate under what circumstance do you reject CSF samples?
So I think yesterday, you remember if you were on the feed, I was saying some of these specimens, even urine that you would think is easily voided, can be a golden sample from someone with a renal injury. So for CSF rejection criteria, you should hold on, analyze the sample. So what are some of the reasons that will make you reject a sample? Is it mislabeling, misidentification? You keep the sample, work on the sample. The only thing that will make you reject CSF is when you have sample that says CSF, but you can see a stool in it, or you can see something which is not CSF at all. But any fluid sample, kindly work on it. Produce your reports down, and then go ahead and do the investigation. Even for bloody CSF, the only test we don't recommend you do is the cell count. But aside that, you do your cultures and everything. I remember sometime we had CSF brought to the lab in a penicillin bottle, those old time injection bottles with the plastic cap, the rubber-like cap. And, you know, there are remnants of drugs in there, but we still went ahead and worked on it, and we still cultured something. So you just don't say, oh, this is from a sample, it's in a container which has antibiotics, so we won't recover anything. You work on it, keep the report down, and go ahead and do the troubleshooting and find out what really happened. So please, in fact, you can keep CSF. What is necessary is that you culture it the first time and keep it in the fridge, so you are able to sort out whatever it is before you reject. Thank you.
Thank you very much. And I think it is important. I remember we ever had a sample in EDTA tube. It had stayed for more than a day, and this is coming from a hard to reach area. But surprisingly, nobody thought. We were able to isolate some stuff that were suggesting meningitis. Wow. So if it had been rejected on some of these criteria, then you probably wouldn't have supported whatever they were looking out for. So I think CSF is quite precious. You go through a painful process to take, and it's okay we heed to this, that let's work on whatever CSF we get, then go further to investigate if there is a need for you to assign that results to the patient or not. At that point, you may want to discuss rejection, but don't let them take the sample back without you working on it. I think that will be very helpful. So for facilities that do not run culture and sensitivity testing, and clinicians request for one for patient who is not mobile and needs to send the sample to facilities that runs it or in a public health reference lab, how do we go about it if we don't have the sample bottle?
The sample bottle can always be gotten. What I thought we were going to ask is the time for transporting and what can happen in that time. So the sample bottle, usually you can always get it, because for tests, for most laboratories, before you get the container, you should have paid for the test, unless you are, let's say, on the ward that the bill can be put in there. So you can always arrange with a sister facility. Wherever you go to run the test, they can get you the bottle, the sterling tubes for the CSF.
That's okay. Thank you very much. But so I think the important thing is, once we get a sample that we know what they are looking for, at least let's see how best we can work on it. And in this situation, I don't think it's going to be something that is routine, that every day, if you realize every day there's a request, then as part of your logistics and consumables, you get tubes. so that you can provide them to the clinicians, to the wards, to the emergency, for them to collect the appropriate sample. If even you have to train them to give you the right, then we shouldn't always assume these people know, not the case. We move through major health facilities in Ghana, and CSF is not things that even clinicians are all comfortable to do. People had to be trained specifically for that before they were happy to collect CSF, even when there was an indication per the guidelines for meningitis or severe malaria. So please, when we get the opportunity, let's educate and provide what people need to collect the right samples for us. Okay, so I'm not seeing other questions. Possibly, let me get to YouTube and Aduamwa Thompson. Please, Doc, after taking the sample and you realize there is air bubbles, what will you do to remove the bubbles from the sample? I'm not too sure which one it relates to, whether it's a CSF or it's a blood.
I think it's with the blood.
Okay.
But the bubble on the top, on the surface of the blood is an indication of bacterial growth. Yours is not to remove it. So evidence of bacterial growth in the culture broth is turbidity, coagulation, specks or flakes in the medium, hemolysis of the blood, and then bubbles on the surface of the medium. It is a liquid medium. So once you bring it out and you see the bubbles, it tells you that there's evidence of growth. You can go ahead and subculture onto your bladder, chocolate and maconke. Thank you.
Thank you very much. So Odami Nathan Okai had also asked at what time you may want to stop plating your blood after the cease. Is it after the 3rd to 6th day? I think you answered that. The question is, does it mean there is no need to plate the blood till the 6th day? I mean from 3rd to the 6th day.
From 3rd to the 5th day, you don't have to plate. It is the 6th day you bring it out for your last subculture.
Okay. Thank you very much. All right, so Kodo Brilliant has some questions. Please, what sample container should be used for CSF sample collection? And 2, do you accept CSF in your lab where you don't do bacteriology, but only gram?
Yes. All right, so Mr. Kodo, the CSF container for hematological analysis, you need EDTA tube. For culture, you need sterile sterling tube. It is small in size with a white cap. For chemical pathological analysis, you need your auxiliary tube because we are going to check for glucose. So fine, you can do your gram. If you don't run, you can do even Z10 for them. We should recover something from that. But please remember to concentrate the specimen before you gram.
Okay. Thank you, Doc. Diane on YouTube.
Or you do anyway, spread. Thank you.
Okay, sorry. Yeah, there was a break, so I thought you had finished. Sorry about that. Doc, can you hear me, please? Doctor, can you please hear me?
Yes, please, I can hear you. Do your AFBs for them. If you don't have culture, you can go ahead with that.
Okay, thank you. So Diane on YouTube has a question, and I think it's about the order of operation. Do you do your counting, spinning before you culture the deposits?
Dr. Jesse, you went.
Wow. Can you hear me?
off a bit, but if I got you.
Hello.
Hello, Dr. DJC. Hello,
Yeah.
Doc. Can you come back?
I think Diane on YouTube was asking the order in which you have to do your culturing, counting, spinning for the deposit. What is the order when you receive the sample?
When you receive your sample, you do your macroscopic identification. You do your cell counts for your cells, your white cells, before you go ahead and spin for your gram and your culture. So macroscopic identification, your cell count, and then you spin for your gram and your culture. Thank you.
Thank you very much. So Fred is asking, why do you have to incubate for 21 days when you suspect endocarditis?
Because it takes a long time to grow. That is how that bacteria behaves.
Okay. Thank you very much. I think that's what I have on YouTube. And just quickly to run through some of it. But Daron, can you now unmute?
Yeah, Dr. Edujesi.
Okay, please go ahead and ask your question.
Yes. So just two quick suggestions with respect to the sample collection tube. In addition to what Dr. Okan had mentioned, for the purposes of culture, there's also this tube that it's called the TI medium, where CSF samples are put in, and the sample, when you put in that medium, can last up to like 3 days, so that laboratories that are far or they don't do the cultures, they can have the opportunity and then transport the sample in a TI medium to the labs that will perform culture. However, the caution here is that because the organisms are fastidious, it means that the trans-isolate medium, which I call the TI medium, is not supposed to go on ice. Then my second suggestion or add-on is that the country Ghana is practicing the case-based surveillance as far as bacterial meningitis is concerned. So in addition to all the tests that we've made mention of, a fourth sample, either in a cryotube or a plain tube, should also be taken and then sent to there are designated labs within the country where PCR is being done, so that we'll be able to keep on with the changes in the genomic structure with respect to serogrouping and serotyping of bacterial meningitis. Thank you.
Okay, thank you very much, Daron. But I think it's good you have a good discussion with your team, the clinical team. I know the clinicians or the anesthetists who will be helping with the CSF tap will take into consideration the volume that can be collected at a time. It's quite advisable you don't do more than 3 mils before you start sucking the brain. So if maybe I'm not mistaken, I'm getting it like you may want to do 3 tubes. So the volume should be important so that we don't also end up causing harm to the part. At times,
Dr.
what
Dennis,
we use in
can I
the
come
lab,
in?
we can keep. Yes, please.
Hello.
So with regards to the volume, actually, if you are looking at the alicot that we even use for the cell count, I mean, what we use for all the other processes, if you are really doing it very well, you still should be able to get some volume, because in Kolebu, for example, where we actually send our samples for molecular studies in Gambia, you know, they have this lab that does it for all the meningitis belts. It's just the sample that gets to the microbiology. We make sure we maximize the usage, so that, your loop size is about 1 out of 500 mils. So how much CSF specimen are you taking? Because just as Dr. Orkan was trying to reiterate, even in children, look at the volume that is being produced. And just as you said directly, if you keep on doing that, at the end of the day, you might also put the patient in danger. So we should treat the little that we receive in the lab as if we are handling some gold. And definitely we'll be able to, because for all these years I've been in Kolebu, we always are able to process and still allocate some and send it to the Gambia for processing. So thank you.
Yeah, so that's what I was driving at, that instead of
Yeah.
doing the tap into 4 tubes, let's rather take aliquots from what we process in the lab for such
Exactly.
surveillance purposes, because the volume required for the PCR, we can get enough rather than discarding because, oh, this one was for chemistry. So once it's done, that is done. No.
No way.
We be mindful of that. Yeah. Okay. Thank you very much. So Dr. Nyakun, you can come in with your question.
All right. Good evening, bosses.
Yeah, good
Sir,
evening.
please,
Go ahead,
can I-
please, and ask your question.
right.
Yeah.
Please, I'm calling from OT. I'm also from OT region. And then some of us have never had the opportunity to do some of these things. And I really thank the organizers for this program because it is very impactful. But my problem is, I don't know if the leadership can do something for us so that we in this special case can have access to doing some of this microbacteriology, which will also help us. That's my intake. If something can be done for some of us in the rural areas. Thank you.
So, Doctors,
Yes, sir.
it will be good. Maybe you have further discussions on this. What is your facility? What is the requirement over there to set up? Are you making the case for the setup? Are you having the need that you have to be referring cases? And for that matter, you want to do the setup over there to be able to provide the care that is always going out of that facility. These are some assessments that you as a scientist will have to do, make the case and get the basic things required. Do you need a cylinder, the Benson burner? Start with the basic gram. Then you can start adding on, as she described from the first day, the things you require to set up for cultures. It comes from what you are putting over there, knowing the situation in the facility. And once the case is made, if it's not forthcoming, you may want to call on leadership to start speaking to your facility and help provide what you require to perform what you need to do. And that is where your regional MLS and all the other team members will come on board. So it starts with you. Assess and know what is needed to be set up. You start the processes. But you can always link up and see how best. I've worked on projects that we went assessing facilities and we needed to get them some basic things. But that was a project. But if you need to do that, make the case in the facility and let them start working out. And I think you'll be able to have the capacity available. If you need hands-on training, then you fall on senior colleagues like Esther and Michael and the rest so that they can come over and train you, or make a case and go to their lab for 2-3 weeks a month and go and learn and bring it back. So that one, I would say, I want to see you taking the initiative. Then you see how best other senior colleagues can come in to support you.
All right. Thank you, Doc.
You are welcome.
Reading.
Yeah, Esther, if you want to add on.
Doctors, that I am also from OT region. And so
Oh, okay.
do all our best to help. So, like Dr. JC has said, take the initiative, and then when everything is grounded, we can come in with our weights. Thank you.
Okay. Okay.
All
Thank
right.
you, Doc.
So OT is it Dambai, Ketekwache, Jasikai? What is
Dambai,
like?
Dambai Health Center. Yes, please.
Oh, okay. All right. All right. So you take the initiative, and I don't know if the director still remains. He's a very good friend. He used to be in Kintampo, moved to Brekum,
Yes.
Shinya, Upper West.
Okay.
Yeah. He's
Oh,
also
okay.
a lab in the lab. So please take the initiative, and the director, I believe, will help you.
All
If
right,
it's
Doc.
not well, Kane, call on us, and we will all make cases for you. Okay.
All right, Doc. All right.
Yeah.
Thank you.
Yeah. Your original MLS is also a good one, David.
All right. Thank
Okay.
you.
So that's okay. So Farouk Marok has this question. Please, Doc, can you please reiterate the names of sample bottles for CSF? Because I think Doc, please take it once again. I know you've done it, but if you can rehash it.
For the CSF bottles, you need an EDTA tube for your cell counts on the analyzer. You need a tube for chemical analysis. And since we are going to be running glucose, you need an oxalate tube. And then you need a sterile, tight cap tube for CSF. And that the name is Sterling tube.
Doc, are you done?
Yes, Dr. Edidesi, thank you. I'm done.
That's good. Thank you very much. But I want to add that, please, these things are in the books. Make sure you've printed them, you've labeled them nicely, laminated, and is on the ward, in the theater, at the emergency point, and even in the lab, so that you don't have to memorize these things. Make it available to all, so that anytime they are collecting CSF, you have it available. They will collect the right samples for you, and we will not be talking so much about rejection and the rest. So please, as Ray has them, provide these things as guidelines so that people can know what to do at every point in time. Even when you are away in the house, they can collect appropriate samples for you. Okay, very
Hello, Doc.
insightful. Yeah, Michael.
Yeah, I think there's one more sample type. I spoke to Esther, but it looks like it skipped a bit. So maybe I'll just hash on it briefly. For individuals that also have hydrocephalus, sometimes they also put in shunts or implants to make sure that they can also drain some of these fluid over time. So at times when the doctors are also suspecting the shunts to be contaminated or the brain blood barrier to be breached as a result of the shunt over there, they can also actually present CSF samples from those taps. So those ones are actually at the upper section of the spinal cord, as against the one that Esther described. And those ones, because there's already been a breach by placing the implant over there, we tend to actually have even the usual specimen and some isolates, which are not like the typical Neisseria, strep pneumo, and all that. So if those samples also come to us, please, it's even advisable that in the first place, when we are culturing, irrespective of the age, we can also add a differential media, that is the McConkey, because we turn out to even have some gram-negative organisms also growing. And then that will also help speed up with your diagnosis, because even the simple, you knowing that is a gram-positive, gram-negative, lactose fermenter, non-lactose fermenter can actually shift the direction in terms of treatment for the doctor. So these are things that we have to also look at. And sometimes they can actually even cut a piece of the shunt for you. So all these things, please, we have to really pay attention to them because they are very, very important in patient management. Thank you.
Thank you very much. CSF 101, this is the advanced version and happens in most specialized labs. But thanks for adding on, much appreciated. So, Doc, Antwi Godwin is asking this question. What's the gold standard for CSF examination? Is it a gram stain, culture, antigen test, or PCR?
Gold standard, gram stain and culture.
if you are privileged, you have the rest added on.
Exactly.
Thank you. At least I know now there's PCR, the multiplex platform that can look at 3 organisms at the same time, especially if you have the real time. So, but at least gram, ideal, add on the culture, excellent, and the rest is when you have the resources, mostly for surveillance and the other, but it's quick to help you if it's available. Okay, so I think those are, is it prudent to take 2 samples for manual blood culture? Obed Odoye Asiedu. Doc, would you want to look at that?
Yes, so several studies have been done into why blood culture positivity rate is low. And it was realized that the one sample was not helping. And so ideally, and especially with the automated versions, you take an anaerobic and aerobic batch for the first time. So you take 2 samples for the first time. And in between spikes, you take another batch of aerobic and anaerobic for a second batch. So you have 4 bottles in all. And that is what recovers. It gave a high positivity recovery rate in that study. So it is because usually we are running 1 sample. Ideally, we should have 2 samples, and if 2, aerobic and anaerobic, and then another set. So 4 bottles in all. But this is the case in my facility. We are charging 200 Ghana cedis for a blood culture. And so in 2 hours, in less than 2 hours, you have to get this amount of money for blood culture, 4 bottles. And so it is because of costs that we cannot get to enjoy the protocols that we have. So ideally, you should take more than 1 sample for a high recovery rate. Thank you, Enoba.
Thank you very much. So I think Abdul Latif Denjima Fudu, I think this is what you were also trying to put across, and Doc has, but what your question was suggesting, would you want to put all together in 1 container and grow them? So an ideal pathogen is expected to grow on both sets. Okay, no, I think you still spoke about both, but Doc suggests that if you want to do 4 sets, that in that research was found to be ideal. But cost. Then we go with 1 bottle. So did you say CSF for cell count on automated analyzer should be put in EDTA tubes?
Yes, please.
Nohela Isaka Kore is asking that.
Yes, please.
Okay. So let me see. Thomas Dankwa, can you please raise your hand? Unmute and ask your question.
Thank you, Dr. Esther, and for your presentation. I think the last question that the gentleman asked, which has to do with the measuring of the WC on the automated hematology analyzer. Let's put a caveat here. It is not all hematology analyzers that will do that. For 6-month machines, they have body fluid chambers in which that is done. So you don't run your WBC count on the hematology machine. There's a chamber in which you have to do the cell count. And so let's take note of that so that we do not go and be running CSF directly like we do for a full blood count. Thank you.
All right.
Dr. Dankwa is my head of department at Kolego Teaching Hospital. Thank you, Doc.
Yeah, so when those who know their systems, actually, I happened to meet the 6-month guys and they mentioned that they have even developed for urine analysis. So that's good. Thanks a lot for adding on. Yeah.
Hello?
Yeah.
Dr.
MLS Gato. Yeah, please hold on. Please hold on. Make that hold on.
Yes. Okay.
So MLS Gato, I think your question, I will advise you contact other colleagues. They can guide you. I know Reverend Aiku can help you get some blood culture containers and bottles and stuff. So contact colleagues and others for such. Especially there is a lab professionals market where you can always go and source for items. So ensure you are part of the Lapreneur and it will be easy to always get your items. As you put it on the platform, people will start contacting you. All right, so Megdad, please can you unmute and ask your question?
Yeah, hello, good evening.
Good evening, please go ahead.
Yeah, I would also like to make mention that in taking the CSF sample, they shouldn't forget to reserve some for cytology, because we also tend to do a lot on that. So aside the microbiology, they take sample from microbiology and that of chemistry. So in cytology too, we also tend to use some. So in taking mostly, I think what I know of is mostly they take it in three levels. One for microbiology, then the other one for chemistry, and then the third one for cytology. So I would want to emphasize that the cytology, they shouldn't forget of us. If they are picking CSF sample, they should remember pathology also. So that we do the cytology for them. Thank you.
Okay, thank you very much but I think it all comes to what is being requested. Do we have it as a panel? And do we have cytology available in all places doing that? So it's important we all have these discussions at a clinical level and know what is available, what requests and support we can all provide for the care of our patients. So thanks for adding on that. Cytology can also come in when CSF is on board. All right, so Obed.
Thank you very much, Secretary, and thank you to the very big thank you to Dr. Okain and then Asari. Please, I would like to ask, sometimes CSF samples come in TI mediums, the transport medium. So it is very difficult. I don't think it will be necessary to do the, it's going to be impossible to do the cell count and then also do the initial gram stain. So will the preliminary results be necessary?
Yes, so like you have rightly said, if you look at the protocol where the TI medium is used, it goes straight to the culture. There is no gram, there is no cell count. So it goes straight to the culture. For the workflow, TI medium, straight to culture. Thank you.
Okay, thank you. All right. Paul Safo, your mic, you are unmuted. Would you want to say something or please mute up? So Daron Davis, I think Michael mentioned CSF. That is a special surveillance process. So if your CSF gets to Kolebu on surveillance basis, it's likely that is how they handle it. They do the PCRs in the Gambia. So what temperature is required for the preservation of CSF and how to transport the sample to different facilities? Doc, you may want to repeat that for the last time, I think. Maybe for those ones, I wouldn't read them again because you've answered it previously. But can you take it again? Temperature required for preservation of CSF and to transport it to different facilities. Dr. Okai.
Sorry, I was muted. Sorry.
Okay.
So CSF, if you have to transport it, like we have heard through Baron, the TI medium can be used. However, if the sample is kept in a fridge before you work on it, you may lose some of the pathogens. So it is best to take the sample to the lab as soon as possible. Culture it first before you go ahead and put in the fridge for later use. Thank you.
Thank you very much. So, GS, I think you can take over and close the session. Thank you very much, Dr. Okine, for your presentation and for educating us. So, GS, can you please take over?
Doc, you have done all the work. So I think you should close. I have nothing to say, only to say thank you to our presenter and membership. And we also encourage us to go on YouTube, subscribe, like the page, comment, share the Gamls TV with our members. Thank you very much. Piero, I'm done.
Thank you very much. So,
and I extend greetings from the financial secretary and the vice president.
Oh, that's fine. Vice president is now a Togbe. So, Togbe, thank you. Well done. And finance, thank you also.
Good job. And the facilitator. We appreciate you.
All right. So, thank you very much, colleagues, for your time. And those on YouTube, we appreciate your staying over to watch. Let's meet tomorrow to finalize the sessions and for the final part of the presentation. Have a very good evening.
Thank you very much. And greetings to Edwin Nomesi.
A very good evening to you, my mentor. Great program, great organization. Much love, sir.
Thank you. Dede Kwanzaa. Greetings to you.
I think we have to continue the session with greetings to individuals.
Yes, sir. Yeah, sure.
Very necessary.
Dr. Dennis, good evening.
Hey, tell me. Maritime people, I hope you are doing well.
By the grace of God.
Thank God. All right, so let's have a good time together.
Thank you. I hope you are all fine.
Hello, Dr. Jesse.
Okay. Ghana versus Mali, 7 o'clock.
Hey.
Footballers.
Guys, let's go watch soccer. It's almost time.
Sorry. Sorry, Might go on.